Hello, everybody. Welcome to the ATS Critical Care Assembly Early Career Professionals Working Group Virtual Grand Rounds. I'm Yuri Maidah. I'm thrilled to be moderating today's session together with Katie Connell on disparities and determinants of critical care outcomes. Today's session highlights the ways that patient, provider, and system-level factors intersect to shape outcomes in critical illness. We have two outstanding speakers who will share evidence and insights that challenge us to think differently about how we deliver critical care. We will reserve all questions for the Q&A portion at the end. Please feel free to post your questions in the question and answer box throughout the presentations. Our first speaker is Dr. Maidah Yaqoob, who will present on disparities in pulmonary embolism. Dr. Yaqoob is an assistant professor of medicine in the Division of Pulmonary and Critical Care at Cedars Sinai Medical Center, where she also serves as Associate Fellowship Program Director and Director of the PE Response Team. Dr. Yaqoob, thank you for being with us here today. The floor is yours.
Thank you so much, Yuri, for the introduction. And thank you to the Early Career Work Group for inviting me for this talk. Okay, so I wanted to be a little clever with the topic. So we're talking about unclotting the system and looking into the disparities of PE treatment. These are my disclosures. By the end of this session, I hope that the participants will be able to define and contextualize disparities, recognize evidence of disparities, analyze trials and research gaps, and propose actionable solutions together. So we'll start off with the definition of disparities. According to CDC, health disparities are preventable differences in burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged population. So more simply put, this is the difference between groups, difference between the health and the healthcare between groups that stem from broader social and economic inequities. So these socially disadvantaged population, though, can traverse more than occasionally between a variety of different minorities that makes disparities even more complicated to tease out. So before we delve into the recognition of disparities, it's important to address how we document and record such data. There's a wide heterogeneity to report PE-related mortality in national databases and worldwide. A study that was done by using WHO database for 123 countries found that there was a wide heterogeneity in reporting the PE-related mortality in specifically low-income countries. And that was probably because of lack of resources. And most of these mortalities fell under cardiovascular death category unless they were diagnosed by autopsy. There has also been a flux in the definition of races over the years. When it comes to reporting race and ethnicity, it is important to understand the difference between them. Race is defined as a social, political category, primarily based on physical characteristics such as skin color, whereas ethnicity is a social category defined by cultural language and history and such. And there has been a growing diversity in the US population, and how the census has collected and categorized information has evolved and is largely heterogeneous. According to some surveys, there is also a lack of understanding in general population about race versus ethnicity, therefore self-recording it either incorrectly or not recording it at all. Genders had also recently been broken down and are not classified as sex. And then again, there is intersectionality between all of these groups, and then inaccurate and incomplete information from low-income countries and other social determinants such as illegal immigrants, and therefore loss of data for this vulnerable and marginalized group. So sort of bringing back into the disparities that occur at PE, they occur at each point of care, from epidemiology to presentation to diagnosis, management, and outcomes. With regards to the epidemiology, it is more common in premenopausal women, and previously was shown to be more common in men after the age of 65. But now recent data is now showing us that it's more common in women even after the age of 65. When it comes to risk factors, the transient provoking risk factors, including trauma, immobility, or hormone therapy use, are more common in elderly women with pulmonary embolism. With regards to presentation, looking at the data from the serious PE study that from the Riete group, it showed that women presented less often with chest pain or hemoptysis, and more often with dyspnea. It was also represented in the ICOPR study, but women were also more likely to present with higher incidence of shock and hypotension, higher pulmonary artery pressures, higher BNP, more RV dysfunction on TTE, and also some studies showing presenting with normotensive shock. shock. When it comes to management, it's interesting because the evidence on sex-related disparities with regards to procedures in specific is kind of inconsistent. With some data sets will show fewer procedures in women and others show no difference. But this variability largely reflects how we collect and report such data. Data sets used are heterogeneous. Small retrospective studies showing no difference, whereas large national database such as NIS showing less procedures for women depicting system-level behaviors. It's important to note a large data set study called REAL-PE that was patient granular data looking at primary and contemporary groups, with the contemporary groups ranging in the years 2019 to 2023. And it showed that women received less procedures in the general PE admission group, but when compared to patients who did get procedures, women got more mechanical thrombectomies in the earlier era, and this kind of waned off coming into the contemporary era in between the 2019 and 2023, the years of 2019 and 2023. So this is an NIS study data using the NIS database from 2016 to 2019, looking at intersectionality of race and gender. And here you can see that women constituted 52% of admissions for PE, but underwent less procedures, especially the Black females who underwent 25% less procedures than the other groups. Also evident is that this is also data from NIS, where women undergoing percutaneous thrombectomy had a higher incidence of mortality, post-procedural bleeding, vascular complications, and blood transfusion. And some of the hypotheses that the authors proposed was that women present late in their disease, therefore portending higher mortality. And perhaps their anatomical structure is different than men, and we use the same standardized catheter size. So maybe their iliofemoral venous structure is different. Therefore, they had more vascular complication and post-procedural bleedings. And is there a signal that antithrombotics work differently for men and women? Therefore, women had a higher propensity of having blood transfusions. This study also showed, interestingly, that women had a higher incidence of other associated comorbidities, such as shock and acute respiratory failure, but they were discharged at the same time as men, but they were discharged to other facilities more than men were. With regards to long-term outcomes, though, women are less likely to die at 30 to 90 days. Recurrence is more common in men, and there is more incidence of post-PE syndrome in women compared to men. So in 2025, it is very important to talk about gender-associated disparities. We have to pay attention to gender-associated hormonal therapy and the risk of thromboembolism, where male to female cohorts have a higher incidence of VTE than female to male cohorts. And Italian studies showed that the prevalence of VTE was higher for patients who received therapy at more than 37 years of age and for longer than 15 months with estrogen-only compounds. So therefore, the World Professional Association for Transgender Health recommends prescribing transdermal estrogen based on age of more than 45 and if they had a prior history of VTEs. And also, it's important to realize that the transgender patient population faces major access and coverage barriers. They deal with fragmented care, underscreening, so they are a vulnerable population. There are also issues with studies on hormone replacement therapies with various formulations and heterogeneous mode of administrations in multiple studies, and the outcomes have not been sufficiently powered for this group. So higher dose and continuous use is associated with increased risk of thrombosis. So when we see these patients in clinic, that's something to keep in mind. Pregnancy, very important to realize that Black women had higher incidence of PE rates during pregnancy compared to white women. And Black women who delivered by C-section have actually twofold greater risk of PE than white women, and also have increased risk in their postpartum phase. So at every single phase of their pregnancy and peripartum period, they are exposed to higher risk. And then women undergoing medically assisted reproduction are also a vulnerable population. There is no consensus on prophylaxis for this group. And the proposed, from the British guidelines, the proposal is that there should be a VTE risk assessment that should be documented and shared with appropriate providers, because they would get their medically assisted reproduction care somewhere else, away from their primary providers, with disconnect between them. And there should be a repeat risk assessment that should be performed if they meet certain conditions like ovarian hyperstimulation syndrome that would increase their risk of thrombosis or ongoing pregnancy with factors like hyperemesis gravidarum. So this is a table that I formulated from a majority of the major trials that we have in this in our PE and with regards to thrombosis, and we see that across 2 decades of PE research, female participants have kind of hovered around 40 to 50%, but none of these studies have sex-specific outcomes. It really underscores the need for equity, not only in access but also in evidence generation. So what can we do to decrease sex-related disparity in this group? So I categorized these into 4 different actions that we can take. So with regard, when you think about detection, we need to sharpen our detection by considering atypical presentation that women have, keeping in mind the sex differences that women have when we are taking care of these patients, maybe embedding EHR prompts for situations such as pregnancy, hormonal therapy, and postpartum states that will make the providers think about taking care of these patients with that in mind. With prevention must be tailored and use transdermal estrogen patches when possible, providing peripartum care for high-risk groups, standardizing the postpartum and fertility-related prophylaxis, and when it comes to men keeping in mind that they do have a higher risk of recurrence, so keeping a close eye on them while they're being treated with anticoagulants. Access, we must ensure equal access to advanced PE care. I think it's easy to say, but really, I think the crux of this is going to be streamlining our transfer processes to the tertiary care facilities where these advanced therapies can be provided. Auditing our PERT activations and procedures rates by sex, and integrating multidisciplinary approach to our PERT teams, including OBGYN and hematology and through our PE response pathways. And with regards to research, the future studies need to have sex stratified outcome analysis, not just counting women, but evaluating whether the outcomes differ for different measures that we take. So as we step back a little from pulmonary embolism specifically, it's kind of worth remembering the broader context we're working with here. So the US is changing dramatically. You can see on this figure that by 2050, people of color will make up a majority of the population. But our health systems, clinical trials, and quality metrics are not really depicting this population. So this demographic shift alone is a call to action because our data, our therapies, our delivery modes still don't reflect this diversity. The figure shows why disparities persist, not just individual risk factors, but structural ones. So here you can see like structural issues like neighborhoods people live in, the food, transportation, the economic and safety nets, and then racism and discrimination here is the outer ring of this model influencing every layer, the environment, the healthcare access, and ultimately the outcomes. So it's very complex. We have multiple studies that have shown us that African Americans have a higher risk of VTE as compared to other races, with a lifetime risk of 11.5% in Black adults compared to 6.9% in white adults. And Black adults have an increased incidence of rate of 30 to 100%. As you can see here, the Black patients hospitalized with PE are younger, with a higher severity of disease compared with white patients, and Black patients are less likely to receive an intervention overall. Risk of procedures such as surgical embolectomy was much higher in another study, and higher risk of intervention only in life-threatening PEs. Mortality difference between races. So here you see in this bar graph that Black patients have a higher risk of mortality from acute PE than white patients. And also as a hook for my next slide, looking at the Asian and Pacific Islander population that have the highest risk of mortality. Black patients develop CTEPH at earlier age and have more recurrence. Interesting is that Hispanic populations share similar social characteristics as Black, but they do have lower mortality, putting into question if there is a contribution from other biological factors that might contribute to this. And here another graph re-emphasizing what I just mentioned. So we were curious about the mortality in the Asian and the Pacific Islander group, so me and several of my colleagues got together and looked at the national inpatient sample and did an analysis and noted that in this group, there was a higher mortality, a longer hospital length of stay as compared to other groups, even though they belong to a higher socioeconomic status. So this puts into question several other factors like cultural barriers. Maybe these patients present late in their severity of illness because they don't want to go to the hospitals, or there is hesitation in being enrolled into clinical trials and such that are not captured in our analyses. So this is another table that I created from the major trials showing the distribution of races in a variety of different trials. And we see a striking pattern that nearly all of the studies were conducted in cohorts that were over 80 to 90% males. And Black patients who overall have a 40 to 50% higher incidence of venous thromboembolism often make less than 5% of the enrolled subjects, and the Hispanic and Latino even fewer. And then this other group, which is uncategorized, had other minorities that are not identified. So worthy to mention other disparities such as obesity, elderly, and geographical access that I won't go into too much in detail because of lack of time. But obesity is a major modifiable PE risk, and it's underdiagnosed, underrepresented. And some of the things that we can do for it is include high BMI cohort in our RCTs, improve CT access and scanner capacity, which I'm sure a lot of us encounter in our day-to-day practice. When it comes to elderly, they have a higher PE incidence and mortality, but are less likely to receive advanced therapies based on studies. And they are excluded from our clinical trials more than age of 75, renal disease, or frailty. So we need to design geriatric inclusive trials and base care on physiologic, not chronological age, and probably expand our post-PE rehab programs. When it comes to geography, mortality and therapy access vary sharply by zip code and hospital resources. So rural or low resource centers lack imaging, interventional, and follow-up infrastructure. What we can do for that is build regional PE or tele-PERT networks, map PE therapy deserts, and incentivize cross-hospital equity partnerships. So this sort of raises the question if we have made any changes since the PERT era. And it's interesting to note that large database studies like NIS and data using the CDC Wonder database shows us that our mortality longitudinally has not really changed. But when we look at individualized PERT centers and their data, we do see that there has been a decrease in mortality and there has been a decrease in disparities. So perhaps forming PERT teams and focusing our care on this patient population has made a dent in the individual level, but that has not translated onto a national level. So this raises this need that we have to sort of standardize care when it comes to this patient population. So overall, talking about the potential solutions, I wanted to rear this back onto a system level because we can make changes at each of these individual levels. So at the patient and community level, it starts with awareness. People need to recognize symptoms. We need to improve healthcare literacy. And we need to bring screening and education directly into neighborhoods most at risk, recognizing those neighborhoods and making efforts to bringing that care into that neighborhood. And then at a system level and at a hospital level, it's about standardizing care. So ensuring that every hospital, not just the tertiary centers, have access to PERT expertise, consistent post-PE follow-up, and for PERT centers to be to standardize their care as PERT Center of Excellence and their workflows as well. At the provider level, addressing bias and variability, we also equitable transfer protocols from community centers to tertiary care centers. And on the clinical trial and research participation level, we need to rethink who gets enrolled. So trials must represent real-world population, not just those who live near major centers. And we could potentially use AI to build equitable cohorts. The research infrastructure at funding level is where we can really build accountability by requiring registries, databases to include zip codes, race, insurance, and social determinants, not just the clinical variables, so that we can start recording this and taking action accordingly. At the policy and payer level, the access has to be equitable. So I could talk for another talk about DOAC affordability, but a lot of our patients encounter issues where they're not able to get their DOACs after they leave the hospital. And this needs to be taken care of at the insurance level, and then coverage for insurance. And also we encounter a lot of our patients who cannot see us in post-PE clinic because their insurance doesn't support that. So all of these changes need to be made so we can provide comprehensive care to our patients. And then finally, at the FDA and regulatory level, inclusion must be enforced. It shouldn't be optional. And there should be representative enrollment for our patients in the end trials. And that is all I have for today. Thank you. I'll take any questions.
Thank you, Dr. Yaqoob, for that thoughtful presentation highlighting the real-world disparities in pulmonary embolism research, care, and outcomes. We will next move on to our second speaker, who will discuss the broader determinants shaping critical care delivery and outcomes through the lens of tracheostomy practices. Our next speaker is Dr. Anica Law, presenting Patient, Provider, and Policy, Dynamic Determinants of Tracheostomy Incidence and Outcomes. Dr. Law is an assistant professor at the Boston University Chobanian Avedisian School of Medicine. Her research focuses on how to better inform decision-making during critical illness and the optimal delivery of care after acute critical illness. Dr. Law, we're excited to hear from you.
All right, great. Thanks so much for having me. I'm so glad to be part of an early career professional working group webinar. Early career professional working group is how I got my start at ATS. It feels like my original home. And I was just saying to the folks before everybody signed on that I wish I could stay in this world forever. It's such a lovely, wonderful community to be a part of. So I'm so glad to talk to you today. So a little bit of background about me. So I'm a health services researcher, and sometimes when I tell people that I'm a health services researcher, particularly like my parents, they don't understand what that means. It's mumbo jumbo. So the way I explain what health services research is that I do, my interest is in studying how different people, potentially different patients or different providers, in different places, like different hospitals or states, do different things, like use different types of fluids or adhere differently to guideline recommendations. And then we look to see if there are different outcomes. And we generally try to do that in large databases and essentially try to draw some inferences if there is some natural experiment that we can leverage. Today, I'm going to talk about one section of my work. So this is how I got my start as a fellow, and it's about the incidence and outcomes of tracheostomy. So I think Kelsey is on this, and so this will look familiar to her, but back in fellowship, we had to rotate through something called the RACU, or the Respiratory Acute Care Unit. And it's a 12-bed unit with a pulmonologist, a nurse, respiratory therapist, and it functions a lot like an LTAC. So it takes care of patients with prolonged mechanical ventilation. And before fellowship, when I was in residency, those kinds of patients would just get discharged to an LTAC. And so we would like trach and peg them, and then we wouldn't really see them much anymore. But now we were kind of like taking care of them as fellows, and we were involved in their care. And it was hard for me. It felt like a concentrated unit of patients that that we couldn't really save. And so I thought it was depressing, actually. And the biggest thing that troubled me about the RACU was, is this picture what patients and families thought they were getting into when they first made that decision to get a tracheostomy? It felt like goals of care discussions were a little bit light on the facts in terms of just sort of being able to describe for families what life after trach and peg was going to be like. And so I felt like there was room to fill gaps, information gaps. So today I'm going to talk about some of what we've done in that area. First, we'll talk about trends in tracheostomy, along with some end-of-life decision-making trends in that scenario. We'll talk a little bit about whether or not there are differences in palliative care delivery, and then we'll talk a little bit about patient outcomes after tracheostomy. So first, how has tracheostomy use changed over time in the United States? It's important to recognize trends because from a health system standpoint, patients on a tracheostomy use a lot of resources. It's a highly morbid condition, and it's just for the planning of the health system, it's important to understand the size of the population. So just to define some terminology, we're all familiar with mechanical ventilation, and really we're going to talk about two nested subsets within that. So the first is what we call prolonged acute mechanical ventilation. So this may not be a term that you hear regularly. This is sort of a little bit more of a research term, and we define this as mechanical ventilation that's gone on for at least 96 hours or 4 days. And that can be readily defined in a claims database through ICD-10 codes, because there is an ICD-10 code for mechanical ventilation of at least 4 days. And then within that, there is a group that has that 4 days and also gets a tracheostomy, and that's the group that we're terming prolonged mechanical ventilation. Sometimes that cohort goes by slightly different definitions, like ventilation for 14 or 21 days, but they're actually there's a very close overlap in those definitions. The reason why we distinguish the PAMV population, so the 96-hour population, is because they're kind of the gateway to prolonged mechanical ventilation. So any trends or interventions that occur in that PAMV stage can then affect downstream PMV outcomes. And the PAMV population in their own right also is worth studying, because they also are a disproportionately resource-intense population. They require ICU level beds and nurses while they're in the hospital. They consume 3 times as many resources as ventilated patients who are ventilated for shorter times. And then they often also go to post-acute facilities after discharge. So I'm going to just set the stage for my work. So before I did my work, about 20 years ago, Maria Zilberberg published a study. And so she used nationwide data, the NIS data set actually, that was referenced in the last talk, and they tracked trends in growth of this PAMV population, so ventilation for greater than 96 hours. And they extrapolated the trends between 1993 through 2005 and extrapolated them forward to try to predict what the burden of PAMV would be like in 2020. And they ended up estimating that in 2020, there was going to be over 500,000 new cases per year of PAMV, so mechanical ventilation of greater than 96 hours in the United States. And notably, most of them, over 300,000 or so, were going to be in adults over 65. And so in the United States, the burden of supporting care for that group falls on Medicare, which is publicly funded, of course, as we've heard a lot recently in the news. And Zilberberg was concerned that Medicare and also Medicaid were going to be heavily strained if there were really going to be 300,000 older adults receiving mechanical ventilation for greater than 96 hours. So this was her prediction back in 2008 for what was going to happen in 2020. And I wish I could see you guys and get your interaction. But the question is, were the healthcare systems overrun by ventilation of greater than 96 hours in 2020? And of course, the answer is yes, but not for the reasons that were projected. It was because COVID came, and so we saw a ton of people ventilated for greater than 96 hours, of course. But COVID aside, how accurate would those predictions have been? So my group, we looked at national Medicare data. Medicare data, because like I said, we're mostly interested in adults over 65 who are all publicly publicly insured. And so we started looking from 2011, so not long after Zilberberg's paper, and we see that the trends took a very unexpected turn. So they were climbing up and up and up. And then we see, though, from 2011 that it's steadily climbing down. So this is a graph that is adjusted for the population in the US of adults greater than 65. And you can see a steady decrease from 189 cases per 100,000 adults to 112. And so this correlates to an absolute number of 78,000 cases in 2011 to just over 60,000. And I didn't show this graph here, but we found that this decrease was because not only were there fewer adults in this age group starting mechanical ventilation at all, but among the people who were starting mechanical ventilation, fewer of those were progressing to 96 hours of ventilation. And just objectively comparing the estimate, so here's Zilberberg's estimate of 300,000, and what actually happened was 60,000. So the actual incidence was only about a fifth of what was actually projected. And as I mentioned before, we're interested in PAMV because it's the gateway to tracheostomy or prolonged mechanical ventilation. So this is a graph of the rates of tracheostomy placement as well. And so you can see that among the group of people ventilated for at least 4 days, tracheostomies decline too. This doesn't look like a super compelling downward slope, but it is a downward slope from 21% to 17.5%. So that's actually about a 16% relative decrease, and we don't often see changes of that magnitude in our practices in such a short amount of time. So why did that happen? So what's responsible for this national decline in older adults? Well, one hypothesis is that the palliative care movement actually began growing around the same time in the late 2000s, the early 2000 teens, culminating in some guideline recommendations, including this Choosing Wisely campaign, co-sponsored by ATS and CHEST, which advocates for increased provision of palliative care for patients who are at a very high risk of death. And of course, can we confirm that? So let's see. So this is the slope I showed you before of decreasing tracheostomy. And we also saw at the same time, so this is an overlay, and orange is the DNR rates. And you can see that the DNR rates tripled actually over this time period from 13% to 35%. And palliative care also doubled from about 15% to 30%. So a rapid rise in how we're delivering DNR, how we're delivering inpatient palliative care to these patients. We can't say that any of that is causative, so we can't say, oh, well, the rise of palliative care directly explains this increase in DNR and the decrease in tracheostomy, but we can kind of at least see that there is some zeitgeist, some cultural element going on that's reflecting an underlying shift in attitudes across the United States about life-sustaining care like tracheostomy and end-of-life care. So that's interesting. But is this like inpatient ICU palliative care growing everywhere? And so that's the second realm that I'm going to talk a little bit about what we've done. So I will say I'm at Boston Medical Center. I moved over here about 5 years ago. Boston Medical Center is the largest safety net hospital in New England, and I genuinely love working at Boston Medical Center. I'm so proud to work there, and I could talk so long about how great it is to work at Boston Medical Center. But when I first started working here, I started to notice that there were papers saying that safety net hospitals like Boston Medical Center had worse outcomes when it came to quality metrics, like for example, hospital mortality among patients with sepsis. In fact, the hospital mortality for sepsis is actually a mandate that New York mandates all hospitals report their hospital mortality rates. It's like a key quality metric. But I also knew two things from my work that number one, that hospital mortality can look very different based on each hospital's discharge practices. And I'll talk a little bit about that in a second. And second, that safety net hospitals don't discharge patients the same way that regular hospitals, non-safety net hospitals do. They don't have the same relationships with LTACs or even with hospices, and so they're holding on to patients a little bit longer. So I wanted to explore this quality metric. So over and over again, papers are reporting that there's higher in-hospital mortality at safety net hospitals. And I looked in Medicare data. So the nice thing about Medicare data is that you're not limited to just a little window of hospital data. It's linked to federal data like Social Security death indices. So you can actually measure true death measured from the time of admission. So you can measure 30-day mortality, which is sort of an unbiased outcome metric. So this is what we found. This is a forest plot. And so the right side shows when an outcome is more associated with safety net hospitals. And so you can see here in the top row, indeed, admission to a safety net hospital is associated with higher in-hospital mortality among patients with sepsis, but there was no difference in 30-day mortality, actually. So when you kind of widen the window to a true 30 days rather than whatever the hospital admission was, it was actually no difference. And so as we suspected, this did have a lot to do with differences in discharge practices, but I was a little surprised. I thought that the safety net hospitals would have differences in LTAC discharges, but actually they were the same. So up in this first row here, you can see that there was no significant difference in discharge to SNFs or LTACs. However, we found that safety net hospitals are much less likely to discharge to hospice. And so what this means for the hospital mortality rate is that non-safety net hospitals, they're discharging their dying patients to hospice. And so their hospital mortality looks better because the patients who die in hospice aren't counting towards the hospital mortality. Meanwhile, patients at safety net hospitals, they're not being discharged to hospice, so their mortality counts towards the safety net's mortality rate. We also found that there, along with differences in discharge to hospice, there are also differences in do not resuscitate orders and differences in palliative care. So safety net hospitals were less likely to have those things. So what were the take homes from this? So first, it clarifies what safety net hospitals are doing fine on. So these findings, for example, suggest that safety net hospitals are probably doing just fine with regards to actual sepsis care if their 30-day mortality is not different. So, and in fact, given that safety net hospitals often have, challenges like sicker, complex patients that are presenting later who didn't have sufficient primary care to begin with, it's actually a good sign that safety net hospitals are probably doing a lot of things really well with regards to short-term sepsis mortality. But of course, it does suggest that maybe there is room to grow with regards to palliative care delivery and the subsequent outcomes. So we know that palliative care, especially inpatient palliative care, is a resource that's not equitably distributed among rural to urban areas and under-resourced settings. What we don't really know is, of course, safety net hospitals have a higher proportion of racial minorities who have been known to opt less often for palliative care. So it's less clear if this is a true disparity in terms of poor implementation of palliative care, or if this actually reflects sort of more culturally goal concordant care. And so there's more work to be done there. And so why does all of this matter? Well, we'll go back now to what I was primarily interested in as a fellow, which is understanding what the patient outcomes are after trach and peg. And so these are from the Twitter days before X, before Elon Musk. And so a few years ago, when I was just starting to publish this data, I posted this sort survey on Twitter to kind of prove my point that we didn't have the necessary data to help patients and their families make informed decisions. And so the first poll was, when you're talking to ICU patients and their decision makers, what do you tell them is their 90-day mortality going to be? And the options were 15% mortality by 90 days, 25, 40%. And most people answered, I don't estimate mortality, because most people didn't know what the mortality was going to be at 90 days. And the second question was, when you are counseling patients about the median number of days alive and not in a hospital, not in an institution, not in a post-acute care facility, not in an LTAC, how many days home do you essentially estimate they'll have within 90 days? And again, most people answered, I don't estimate hospital-free days, because we didn't have that number. So that's exactly what we tried to fill as a knowledge gap. So we used Medicare data. This is a Sankey figure, so the width of each band reflects the relative proportion of patients following the trajectory. So on the left is when you get the trach and peg, and then it's like the proportion of patients that go down each path. So you can see here that during the hospital admission, they get their trach and peg, and about just under 10% die actually right after they get their trach and peg in the hospital. Almost everyone else of the 90% discharged alive go to a SNF or an LTAC. And so most of them essentially are not going home immediately, not shockingly. What was sort of surprising is that we did already know that 1-year mortality was high, that it was close to 50%. But what we found here was that actually 90-day mortality was really high as well. So, the majority of patients who are going to die within a year, they actually already died within 90 days. So if you were going to die, you died pretty early on, and most people did die early on. And then we also quantify the number of days alive out of any institution. So we counted days in a SNF, we counted days in an LTAC. And so first we found here on the far left is your hospital length of stay. So from the day of admission to your day of discharge, in blue is 24 days, so just over 3 weeks. Your trach and peg procedure occurs in the middle of your hospitalization. And then we counted out from that date of trach and peg, counted out 90 days, and counted for every single day whether or not you were in a SNF, an LTAC, or in hospital, or if you were at home. And we found that in those 90 days, the median days alive and not in a hospital, LTAC, or SNF was 0. So more than half of the population did not have any days at home in the first 90 days. We also counted 180 days out from trach and peg, and we see now that some patients do eventually go home, but out of those 6 months, the median days alive and at home is still only 32 days. And so all of this information is information that I now do share with my in goals of care discussions with family members, just to answer their question about what life is going to be like or what their average outcome is like. But I don't share that because I expect them to change their decision. It's been shown time and time and time again, actually, that showing patients these kinds of numbers don't change decisions. But I hope that they take this information and they just go in kind of more prepared for what's ahead. So that was a whirlwind of a little bit of work that I've done in this field. So in summary, we've talked about how in older adults in the US, there's a decline now in tracheostomies for the first time. That's unexpected. There's an increase in palliative care delivery in the inpatient setting, as well as a rise in discharge to hospice. There are some differences in how that's administered, and in particular at safety net hospitals and under-resourced settings that require some further work. And then finally, patient-centered outcomes, including days alive and at home, are not great, especially among older adults after trach and peg, and that's all information that patients and families can take and use to inform their future decisions going forward. These are my acknowledgements, and I will stop here.
Thank you so much, Dr. Law, for that insightful talk. And thank you again, Dr. Yaqoob, for your excellent presentation earlier, too. So I think for me, together, these talks really highlight how, structural, clinical, and policy factors really converge to shape outcomes in the ICU. And now we're going to open our floor for questions. So if you haven't already, put your questions in the Q&A. You're also welcome to raise your hand if you'd like to say it out loud, and we can unmute you to speak, and we'll address as many as we can. We have about 15 minutes. And so I think we already got our first question here for Dr. Law. Is there anything that clearly differentiates those patients who are living and getting home? I would presume age would be the biggest factor.
Matt, that is a fantastic question. I actually had a slide on this that I took out because I was worried it was gonna take too long. But yeah, we did actually try really hard to kind of tease apart factors that might predict who was more likely to go home and who wasn't. We actually divided the cohort into different categories based on whether or not they had cancer, whether or not they had chronic organ failure, like renal failure or liver failure, whether they had frailty as well. And we also looked at all the different combinations, all the permutations of those three things. And it turns out that they basically all look the same. So regardless of, which bucket of those you fall into or how many of those buckets you fall into, you essentially have a pretty large decrement and unfavorable days alive at home and out of institution. The only group that significantly did better was if you had none of those things. So if you didn't have cancer, didn't have any form of chronic comorbidities, didn't have any signs of frailty, you might have a better shot. But everybody else kind of lumped into this mass, unfortunately. But you're right, because there was, what I showed was the median, but if you were to take a little closer look, there is that top quartile of patients who do better. And so the question is who's in that top quartile, because you want to be able to guide those patients toward a tracheostomy because they're likely to do just fine. There is probably more work to be done with that. This was all work done in the Medicare data set. So we had a lot of good data at our disposal on a large scale, but of course, some of the more granular things, some of the more important predictors that I suspect are key factors, for example, whether or not you have resources, families, caregivers who are able to really kind of support you. I think those are critical factors that you're just never going to be able to measure any large scale database.
Great, thank you so much. And yeah, we have a response from Matt Christensen as well. And let's see, it's interesting. I have very little knowledge on what LTAC really looks like, but this seems like a severe PICS group and maybe where PICS clinics and intervention should focus.
Yeah, I think, it's funny, before PICS became a thing, I think the 2000s really focused on the cohort of chronically critically ill patients, CCI, and the kind of the buzzy topic of that period was like teasing apart chronic critical illness into different buckets, persistent critical illness, and prolonged mechanical ventilation as well. And then it sort of became clear that, not only do we have to worry about these very obvious, highly morbid populations, but then there's also the PICS population, which, has all these cognitive, psychiatric, and physical manifestations, besides the obvious trach and peg dependency. I think that you're right, that it's all on a big spectrum. But yeah, I think there's definitely lots of work to be done in both realms.
So I have a question for both of you. What I'm curious about are existing evidence-based pathways inherently equity promoting, or can standardized care actually unintentionally widen disparities that exist?
So I can jump into that. Unless Maidah wants to respond first, but I will say, for example, one key example of what you're referring to is our attempt to measure sepsis outcomes. So I will say, it's tricky because you do really want to get better at understanding how to improve sepsis outcomes. And I think measuring sepsis outcomes is important. But I think the example that I mentioned about hospital mortality is a really classic example of how things can actually backfire. So when New York mandates that every hospital reports their hospital mortality, that gets publicly reported, and on a website, all those hospitals are ranked by their performance based on their hospital mortality. And when you start to rank, when you take a biased metric that is affected by things like discharge practices, you then are penalizing safety net hospitals or hospitals that are actually doing just fine from a sepsis viewpoint, which is what you're trying to improve, but they just have differences in how they're doing something else. And I mean, discharge to hospice and palliative care are things that we should all get better on, but you want to be sure that your outcome metric measures exactly what you think it measures, not something else.
So when it comes to PE care, I think the algorithms itself are not designed to capture the minority population because it's so nuanced and it's so sort of heterogeneous. So I think it comes to, like, algorithms are sort of like structures that we follow to provide like expert level care, but the person who's providing that care, it would sort of fall on them to be recognizing those minorities that we're encountering, such as elderly patients. If you have a 40-year-old who's coming in with intermediate high risk PE, you would, who needs an intervention, you would take them for an intervention. But are you biasing a 75-year-old just by the virtue of age and not taking them to the cath lab for a procedure just because of the age, even though their functional status would be normal? So I feel like the algorithms are appropriate, but they have to be enriched by the person who's using them.
Great. Thank you so much. Go ahead.
Maybe, following up on that question for Maidah, if you could implement one change today in reducing disparities in PE treatment, what would you do?
I think really building equity into our daily workflow. There's so much of this that we cannot control, right? Like things that are at a higher system level. But like as individuals, I think we should be recording and following disparities for the patients who are coming to us and making sure that we are being equitable to their care as an institution. And then the second thing that I would like to really push is the transfer protocols. So tertiary care facilities need to have, and along with the community centers, need to have that hub and spoke model, where patients who are coming to these community centers that do not have those advanced therapies need to have a pathway to these tertiary care facilities where they can be transferred by simplified protocols. So such as Cedars Sinai, we have a satellite hospital, Marina Del Rey, and we have a very easy algorithm that triggers the ED physician to contact us to take these patients for advanced care. So developing simple, easy to use sort of protocols for physicians who are really busy in these small community hospitals so that those patients can get care. I think those are low-hanging fruits.
Great. I also have a question for Dr. Law. So I think one thing that I'm thinking about is what strategies can we use to enhance goal concordant care for patients at high risk of tracheostomy, like upstream, to really, before the onset of critical illness, help companies' decisions? And also, like, what's the balance, especially in like some of these other patients, like with limited English proficiency or marginalized populations? How can we like basically kind of walk that line and not be paternalistic at the same time?
Those are two really great questions, and I'll answer the first one by saying that if I knew the answer to that, we would all be done here and my career would be over. I would just be done. Bye. I think that is the $1,000,000 question. I think that everyone has tried to figure out, like, what is it about? They've looked at it from the goals of care discussion perspective. They've looked at it from, creating more predictive models. There's the ProVent score that can be used to predict 1-year mortality that unfortunately, when applied in an RCT setting, did not change anybody's minds about what decisions they were going to make or even their understanding of what was going to happen. All of that is so discouraging. And I think that even looking further upstream, I think that there is some data to suggest that even our efforts to improve advanced care planning discussions in an outpatient setting are not as durable as we would like. That there's conversations that you can have, and then there's what actually happens in the ICU. And, a lot of that over time, I think that used to bother me a lot as a fellow. It used to really pull at me in the RACU, but I have come to terms with over time with just like, as a human being, how difficult it is to be faced with these decisions in the ICU and to try to make the decisions that, like, it sounds like physicians think that you should make in terms of transitioning to, whatever it is that they think that they would do. I would say that I think that some promising approaches include thinking more about time-limited trials, as in having the family involved in the actual decision-making of the ICU as early as you can, ideally at the start of ICU care, rather than waiting to day 12 and then kind of expecting them to digest a lot of information in a short amount of time. I think there's power in bringing in the family early on, involving them in the same torturous, day-by-day observations that we're all undergoing ourselves. I don't know if how that will change things, but I think that's promising. That's what Jackie Cruiser and I are hoping to kind of learn more about, how to shape time-limited trials in an evidence-based way. So yeah, I think that question, basically your first question, I think the jury's out. I don't think we know the answer to that. What was your second question again?
Yeah, how do we walk that line between like
Oh, yes.
paternalism and
Yes. Yeah. I think it's so interesting because that is something that when transitioning to Boston Medical Center, I think that we see culturally a lot more patients who do want to, as part of their culture, do want to, do the whole 9 yards, which I occasionally have seen, a lot of moral injury and angst from staff members about, like, why are we doing this and all of that stuff. But I think also, like, I'm impressed that there is a cultural sensitivity that I didn't really get to experience in other settings before. So, like, for example, we had a patient recently who had progressive ALS, who had cardiac arrest when her BiPAP, she was 24-hour dependent on BiPAP, that failed at home. She had a cardiac arrest. She was like 90% brain dead, essentially, when she got to the hospital. And it was very clear to everyone's perspective. Neuro signed off within like a day because they were so clear on the prognosis of this patient. But the patient had like very clear wishes about Jamaican funeral, burial, cultural, and she just needed to make it to actually a month later when her family was going to be present so that everybody could be present. And that was going to require her a trach to just kind of get her to that point. And I think, like, in a different setting, it could have been such a, ethics could have been involved and it could have gotten so ugly and torn apart. But at the end of the day, it was like, what are we doing is this in the patient's best interest? But it was like she had made her wishes so clear. She wanted to try to be alive until X. And so, that happened. She trached her and she made it. And, so I think that it's a humility on the part of the providers that just because it's a decision we would make, it's not the decision everybody would make. Some of us make a decision to climb Mount Kilimanjaro, and some of us would say that's absolutely a terrible idea that I would never want to do myself, but to each their own. So
yeah. And you don't know what decision you're going to make if you're not in the situation as well, too. So, but Pat, I think you were raising your hand. Although we're heading towards the end, so.
I wasn't. My question was a can of worms that we should not open right now.
Okay, so maybe
I'll
this
take
is
it
a
offline.
perfect time to close it. Okay, and I guess you guys can liaise offline. Okay, so I wanted to, on behalf of the Critical Care Assembly and Early Career Professionals Working Group, to thank our speakers and everyone who joined today. Conversations about disparities, determinants, and data remind us how critical it is to bridge science and systems in ways that improve patient care. We hope that you'll join us in future sessions and stay connected. Thank you for being here, and I hope you have a great rest of your day.